The conference has been muted.
All right. Good afternoon, everyone. Thank you for joining us today for our webinar. My name is Monica Beltran, and I am the project coordinator for the Institute for Equity in Birth Outcomes at CityMatch. Before we begin, know that this webinar is going to be recorded if you wish to share that with any of your team members or colleagues. At this time, I have muted all the lines, and they're going to be muted throughout the presentation, but at the end, I will unmute them so you'll have a chance to ask questions. And if something comes up during the webinar, feel free to enter it in the chat box. I will be keeping an eye on that, or press *7 to unmute yourself and bring your question up. So our webinar today is meant to explore the housing issues affecting MCH populations, and this is something that came about because our Equity Institute teams were having trouble with that. So we invited them on the webinar. Here are our presenters, so they can talk about some of the issues that they're coming across in their communities. And to sort of light the way of something that's possible, we invited Ms. Heavenly Mitchell from the Boston Public Health Commission to share with us her program, Healthy Start in Housing. So let me see, presenters, if you could please press *7 to unmute yourselves. Okay. And our first presenter is going to be Rose from St. Louis. So you go ahead, Rose.
Okay, good afternoon. Can you hear me?
Yes, ma'am.
Perfect. I'm Rose Anderson Rice. I'm Program Director from Generate Health and serving as co-lead with the City of St. Louis Department of Health and the St. Louis County Department of Health. And then we also have our community coalition. So we're excited to be part of Cohort 3 with the Equity Institute. And so this is just a quick little picture of aerial view of St. Louis. We have convened our community coalition of folks, and they came up with a name. And so we are Flourish More, which stands for Motivated Outreach for the Restoration of Equity. And here's a quick little picture of a few of the folks. We went through a process to determine what our focus was going to be for the Equity Institute. And as you can see, our community coalition of folks overwhelmingly chose housing. We're also tied to Flourish St. Louis, which is an infant mortality reduction initiative, and that initiative's working on prenatal care, improving prenatal care, infant care, working on transportation issues, working on behavioral health, as well as health communication and navigation. And so our group wanted to contribute to assisting in some way with an issue that wasn't being already addressed by Flourish St. Louis. And so we landed on housing. And so we're currently in the process of working through with the community to identify some strategies, upstream and downstream strategies to work on. So that leads me to kind of what's happening that we're hearing about and experiencing and gleaning from community members. So one, there's this long waiting list for Section 8 housing. So Section 8's taking care of housing subsidies. And our pregnant postpartum moms, there's no preference for them, no appropriate. They don't get added up to moved up to on the waiting list if they're pregnant or postpartum or any of that. It's just first come, first serve. And the waiting lists we're finding are extremely long. And then when the application comes up for a housing site, it's very limited slots available. And so we're trying to figure out now how do we work. Uh-oh.
We're getting some feedback in the back. If you could mute your line, please.
So we're working currently to try to figure out how do we change that? What policies need to be put in place to work on that issue? We also have a partner called For the Sake of All, which is a group who are housed out of the Brown School at Washington University in St. Louis, and they are working to improve the health of African American people in St. Louis, and they have identified several areas. Housing is part of that work, and we had a representative come to our community coalition and talk to us about an affordable housing trust fund that is available in the city of St. Louis currently. And we just found out that it has what it is it's the business tax from businesses purchasing things in the city of St. Louis. The city collects that revenue to the tune of about $29 million a year, but currently this particular fund is being underfunded. There's about $5 million of that $29 million that's supposed to go in there that's going in there, and this is to help with rental assistance in the city of St. Louis as well as public safety. So our partners at For Sake of All are looking at this too, trying to figure out, okay, what's going on with the money that's supposed to be helping with housing assistance, and why isn't the funds going where they need to go? And then we're also finding, and For the Sake of All is going to be releasing a report in January, February of 2018, talking about policies and codes and regulation that's happening in our community as well. So we know that redlining is illegal. Those policies are illegal, but it's interesting enough that there are policies that are creeping up in municipalities that keep folks out of those areas. For instance, we've learned there's a policy that, you can't build any multi-family structures in certain municipalities. Or in order to build in this particular municipality, you can only build on the least amount of acreage you can use is 1 acre of land. And so it's all these little policies and codes that are being created to keep folks from being able to move into communities. And so there is a program called Section 8 Mobility Program, and this is really most of the Section 8 housing availability we're finding is concentrated in high poverty areas. And so a family should have a choice of where they can use their vouchers. And so there is an agency in St. Louis that we're now getting ready to partner with. We're talking to them now because they're working with potential landlords in other areas, like out in the suburbs, to, when they're renting, also be able to accept Section 8 housing vouchers. And so, and then on the flip side of that, talking to residents, potential tenants, so they know their rights and their responsibilities in those living in those houses. And so we're finding that in St. Louis City, it's illegal to discriminate against someone based on how they're going to pay for their rent, but in St. Louis County, you don't have those codes. And so in a lot of the areas where landlords could rent, they can discriminate against you if you have Section 8 and not rent to you at all. And so there are all these policies that we're finding out we're going to need to be pushing against to create better housing opportunities for folks in our community. And then I wanted to share also, so Flourish St. Louis has a cabinet that kind of governs the work of that initiative, and it was brought to the cabinet that one of our housing sites in the city of St. Louis has a really, really atrocious mice infestation issue. And basically it was like, we have to do something about this. So what we're finding is that it's not just a few mice running around, like they're in the walls, when folks are trying to cook their meals, they're in the refrigerator. The gentleman just talked to us last week and said he placed a can of peanuts on the side of his nightstand, and when he came back, the peanuts the whole can had been eaten through, and it just really, not only grossed him out, but he was like, oh my God, I lay my head right there. And so we've been working with him, with the city health department, to have the housing authorities in the city do something to help these residents. There are about 350 residents affected by this. And so we've been trying to broker meetings with them. They canceled 3 of the meetings that we had scheduled with them. And so basically on Friday, our organization, along with health department, city health department, and a state representative and a state senator all came together to strategize on what can we do to move this issue forward. And so they scheduled a meeting on this Friday, like a town hall meeting. It's an emergency meeting because the housing authority site, or the housing authority, were met by, we have an anchorman who does a show called You Paid For It. And so what he does is he goes into the face of whatever's happening, and he, puts them on Front Street. Like, you have to answer his questions right then and there, or you look like you're hiding something. So he did this with the housing authority, and basically they were a little proactive, saying, oh, well, we have feral cats that we have now who are going to go around in this complex and take care of the mice issue for us. And these feral cats have been neutered and spayed and all this stuff. And we're thinking, okay, there are mice in the walls and mice in the refrigerators. How are these feral cats going to help with this situation? So that's our most pressing issue right now we're trying to resolve. We have we asked the tenants what were their most pressing needs, and they were like, one, that they want cleaning products that they can clean up after what's happening with these mice, because you can think about it, there's feces and urine and all that. So they're asking for cleaning supplies. They're asking for, like, glass or metal containers to put their food in. And so we're currently, Generate Health, doing a drive right now, getting folks to bring in things. We've purchased about 100 different containers that we're taking to this meeting on Friday, and folks are Facebooking this. They're talking about it to try to at least help the residents, while we also work with the housing authority site, as well as there's a management company that we're trying to work with to resolve this mice infestation now as opposed to later. So that's what's going on in St. Louis.
Thank you so much, Rose. And now we have Lillian and Gianna from Nashville. And please press *7 to unmute yourself.
Can you hear me now?
I can hear you.
All right, great. This is Lillian calling from Nashville, Tennessee. Thanks, everyone, for joining us today. I do have a poster presentation that was done by our wonderful epidemiology program here for a recent project. And so Brooke McKelvey, Dr. Raquel Quoles-Hampton, and my supervisor, Deanna Allen, who is our division director for maternal, child, and adolescent health. So based on our poster presentation, I want to also share with you all that we are in cohort 3 for the Equity and Birth Outcomes initiative that's going on here in Nashville, and we've partnered with the Metro Developmental Housing Agency, and Gianna Hanson is my co-lead on that. When we first started our project, one of the things that we were focusing on is that we've had some deaths to occur due to safe sleep environments. And the safe sleep environments had to do with these families not being able to afford air conditioning in their homes. Many of the public housing sites that are here in Nashville have been built, in the early 50s. They're made out of cinder block. And so if it's 90 degrees outside, the temperature there in those apartments without air conditioning can exceed, beyond 120. So this is a concern. But I wanted to share with you that Nashville, Tennessee has about, based on our 2016 census, we have about 684,410 people that are here in Davidson County that live here that are residents. And so during the day, of course, it's close to 1 million because people are coming here to work. But we have an issue with overcrowding. We currently are in a housing boom. We have about 85 to 100 people who move to Davidson County, Nashville each day. And that is a lot. So we are really trying to brace ourselves and work around how do we address this overcrowding issue and this influx of new residents that are coming to our city. So if you look at the poster, sleep-related deaths are preventable and represent approximately one-third of all the infant deaths in Davidson County. And between 2013 and 15, there was a spike in these deaths. And during the same time period, Nashville experienced both an increase in population, as I mentioned, and an increase in home prices. The Child Death Review team hypothesized that the increase in sleep-related deaths may be related to the change in the housing condition. And one of the things that I'd like to point out about the housing condition, I know Rose had mentioned about Section 8 housing in the city of St. Louis. We're having an issue with Section 8 housing because many of the landlords that are here, they're saying now that they can get more bang for their buck. And so a lot of them are not accepting Section 8 vouchers. And this is causing a number of those who do receive Section 8 to have to move into those more outlying counties that are closer to Nashville. And so that poses a problem because a lot of these counties do not have transportation, bus transportation, public transportation for these families to be able to navigate in those communities and to possibly come back to Nashville if they have affairs to do here, such as seeing, their doctors for prenatal care or pediatricians or other affairs as well. So to investigate this data on the safe sleep position, the circumstances of the death, the medical history of the infant, social history of the family, and details of the scene and living conditions were examined for sleep-related deaths between 2010 and 2016. To account for residents overcrowding, the algorithm that you see this in Figure 1 was created based on the impressions from death scene investigation narratives and the number of individuals living in the household at the time of the death, as reported on the sudden unexpected infant death investigation form. Overcrowding was determined for deaths from 2015 through 2016. Results indicate that one-third of the sleep-related deaths in Davidson County occurred in overcrowded housing, which seems to suggest that further testing and refinement of the algorithm is warranted. Results also indicate that infant deaths that occurred in non-overcrowded households were more likely to occur in an adult bed in spite of a higher prevalence of cribs or other safe sleep spaces to sleep. Bed sharing was equally common in overcrowded households than in non-overcrowded households, and the prevalence for both was quite high at 75%. This seems to suggest that reinforcement of the safe sleep guidelines related to bed sharing is needed. It would also suggest that more investigation is needed into the reasons caregivers might choose to bed share instead of using a crib, even when one is available in the home. Additionally, infant deaths in non-overcrowded households were less likely to have been placed to sleep on their backs. Higher rates of back sleeping in overcrowded households may indicate that caregivers are aware of sleep recommendations and are attempting to adhere to the guidelines when and where they are able. Lastly, less adult bedding use in overcrowded households may indicate that those beds are fully occupied, and so those families must be more creative to find space for the infant to sleep. And so at the health department, one of the things that we have done, we have partnered with our birthing hospitals here in Nashville. We do provide pack and play, and those pack and plays are from the Cribs from Kids, which we receive from the state, and we're able to provide those free pack and plays for those families who identified that they need a safe place to sleep. We've also tried to look at this issue as finding another remedy if there is overcrowding, if there's not a space for the baby, for a pack and play to be set up. We have ordered what's called the BRICA, and that's spelled BRICA, portable bassinets. These are easily opened up, and they take up a very little space, I should say. and they are able to fold up, after, if you use them, and to be able to pack away, just slide. You can even carry them in your car very easily. So we are trying to use this pilot with our home visiting programs to be able to give those to those families who have addressed that they have very little space in their homes. But with that comes additional education such as, where to properly place these. Of course, they need to be on a flat surface. We also would have to identify if there are pests in the home or pets. And if there are other children as well, we want to make sure that those children are not able to step on the babies or to throw toys down on the baby. So we are addressing all of these issues, and we will develop a handout and the education to go along when we distribute those pack and plays. And then lastly, I just wanted to add that, we have another City Match program that's going on, initiative that's going on here in Nashville with the Collective Impact Learning Collaborative. And so with our Nashville Infant Vitality Collaborative, their housing group, they have started meeting with officials or with property managers here in Nashville to discuss the overcrowding issue and to see if those who are prenatal women or families, I should say, if they would get added to the list first. Because as I mentioned earlier, a lot of the Section 8 housing in Nashville is going away because we have an influx of people that are moving here who are willing to pay upward fees of what some of the families that live here in Nashville can afford to pay. Are there any questions?
Feel free to use the chat box or press *7. And otherwise, Lillian, she'll be at the end to take any questions that you have. Thank you so much. I'd like to invite now Heavenly. Here you go. And press *7 to unmute yourself.
Can you hear me?
Yes, ma'am. You're on.
Thank you. Good afternoon, everyone. My name is Heavenly Mitchell, and I work for the Boston Public Health Commission. I am the Division Director of the Healthy Start Systems Program, which are inclusive of our maternal and child health programs and fatherhood initiatives. So our Healthy Start and Housing Program provides stable, permanent housing to families, and this is an opportunity for us to improve the health of mothers, babies, and our future generations. So a little bit of background history. Between 2007 and 2014, the number of homeless people and families more than doubled. So that was approximately 1,400 families with children and pregnant women in Massachusetts emergency assistance shelter programs. So I can imagine many other cities were experiencing some high rates of homelessness due to the financial crisis that we all experienced, that a number of us experienced, as well as homeowners losing their homes. So for us, homelessness and perinatal outcomes, there's a correlation between being homeless and it having an impact on one's physical and mental health. And with that impact, it increases the risk of poor birth outcomes to include preterm birth. As the slide shows that although there is some research on severity and the aggregate predictor of premature birth and low birth weight, the homelessness severity is greater than that of both smoking and substance abuse. Unfortunately, there's little research to support housing programs that target homeless families, and there's limited or no data to specify the impact on homeless pregnant women. On this slide, which was created by Halfren and all, it talks about the impact of homelessness and housing insecurity and how it has an impact on the psychological and physiological stress. So for those of us who work with pregnant women, housing is a priority, so other areas takes a back seat. And according to the life course perspective, this has, on the maternal health, it has an impact on one's physical and mental health, and their higher unmet need for health services, and they're likely to take care of themselves prenatally as well, and which has an impact on the birth outcome due to allostatic load, and it increases the child's rate of being born prematurely and at a lower birth weight. And again, due to other priorities, moms are less likely to follow up with the well child checkup visits, and nor are they likely to breastfeed. And with those impacts, they're on their child health, they're twice as likely to be in fear of poor health and experience other chronic conditions that will impact their life. So an overview of the Healthy Start in Housing program. So the Boston Public Health Commission approached the Boston Housing Authority to collaborate to address inequities in birth outcomes and support stable tenancy. And the goal of that was to increase the health of women and children across the life course by addressing housing as a critical social determinant of health. It's also important to note that both of our agencies are under the same administrative leadership, which is the Mayor of Boston. So the program goals for the pilot, it's now a program, but the pilot was to improve the birth outcomes, improve long-term health of mothers, infants, and families, and increase housing retention. And for the Boston Housing Authority, it was to improve long-term stability of public housing in Boston, improve quality of life for Boston tenants, and to maximize the impact of housing to benefit the well-being of all Boston residents. Because of the limited number of units that were available during this pilot, we had to come up with a eligibility criteria. And so the women had to be pregnant, at risk of adverse birth outcome based on a medical risk and homelessness, housing history, current housing status, legal history, and they must meet the Boston Housing Authority residential criteria. This slide is a little challenging to see, but to give you some examples of the health conditions of the mom, they had to have persistent asthma, diabetes, cardiac or heart condition, high blood pressure, autoimmune disease such as lupus, sickle cell, cancer, or a diagnosed serious mental health condition. And we also allow for pregnant women who had a previous preterm birth, less than 35 weeks, low birth weight, less than 5 pounds, their child stayed in the NICU for greater than 5 days, birth asphyxia, they've had 3 or more previous pregnancy losses, and SIDS. And if they were pregnant and parenting a child with a chronic condition, they were also eligible. And some of those chronic conditions included trisomy, congenital heart disease, sickle cell cancer, diabetes, fetal alcohol syndrome, cerebral palsy, autism spectrum disorder, failure to drive, spina bifida, cystic fibrosis, to name a few. And in terms of their legal history, they could not have been barred from public housing for a conviction of manufacturing or selling or distributing crystal meth. So they were ineligible for Boston housing if they were convicted of manufacturing or distributing crystal meth, any SORI, sexual offense registry of information, and if they were convicted of a civil rights offense within the last 3 years. That made them ineligible for Healthy Start and housing under the Boston Healthy Housing Authority criteria. So the model builds upon our city's Healthy Baby, Healthy Child home visiting program. Looking at that and looking at what it would take for us to roll out this program and the resources it would take, we collaborated with the Boston Department of Neighborhood Development. The application process for the Boston Housing Authority is very extensive, so we wanted to decrease the stress that many of the families would feel going through this process and make sure that the applications were complete in order to reduce the number of times it would have to go back to the individual for completion. So we held these housing application workshops. We created a client participant contract, and this was an agreement for which the clients would agree to participate in their service plan, agree to home visits, and just agree to be a good tenant. They also agreed to 3 years of intensive tailored case management services. And after the 3 years, the individual will graduate to permanent tenancy. And what that means is they did not leave the unit that they were residing in. They would become a traditional Boston Housing Authority tenant, and that would free up a unit for another family to participate in the Healthy Start and Housing program. So initially we were given 75 units, and that's a roll of 75. So once a family graduates, that frees up that unit for another family to participate in the Healthy Start and Housing program. So just a little background about Healthy Baby, Healthy Child, for which our case management is based upon. As a result of some new administration at the Boston Public Health Commission and our identification of some overarching goals, which included the goal of reducing low birth weight rates between black and white in Boston, Healthy Baby, Healthy Child transitioned to a new program approach and service delivery model in order to increase positive birth outcomes. So it just it defines how we do our work and how our staff interacts with clients and amongst themselves. So this is just a little bit of in 2009, the commission released a public health briefing, and in that we talked about racial disparities in infant mortality and how in Boston the black infant mortality rate was historically 2 to 4 times the rate of whites in our areas, and what the research indicates is that the impact of racism has had a profound effect on the birth outcomes. And due to those women who were exposed to the chronic stress of racism and suffer the economic inequities associated with the racism, many of them experienced the increased physiological changes in their bodies that were detrimental to their health and healthy development of their fetus. So our program approach, it was based on the principles of the following training programs that our staff participated in, and that was the Family Development Credential, Problem Solving Education, Undoing Racism, and Racial Justice. So all of our staff are required to go through all of these trainings. The Family Development Credential, for those who are not familiar, is a 90-hour strength-based approach that's the attendees could utilize the tools from this practice in their own personal life. So it's really transformative. Problem-solving education is a short-term, brief intervention model. And then undoing racism and social justice. We actually went through the undoing racism training, but we've created an in-house racial justice core program for all commissioned employees to go through, and that's a 2-day training. And this just talks about our program delivery, and we wanted to make sure that it focused on the life cycle approach as to the women's health. And so in Boston Healthy Start Initiative, which is one of the programs for which I oversee, was one of the original Healthy Start demonstration programs grants to address infant mortality in 1991. So we have a history of at least over 2 decades of our programs trying to address infant mortality that focused on the prenatal and postpartum care for mom and child. So although there's been some success, there's still a lot more to do, and one way of us trying to do that was, again, working on this social determinant of health. So this is just our commission's, the Public Health Commission's goal to reduce the low birth weight rate between black and white residents, and it was 25%. And these are the reasons why we selected low birth weight. It's an important cause of infant death. It has an impact on health consequences later in life. It's significant racial inequities that exist, and it's a general indicator of societal well-being. Some of the medical risk factors for low birth weight, the infections, the high blood pressure, the preeclampsias, the diabetes, obesity, or poor oral health, and unfortunately, a number of black women are disproportionately affected by these conditions, as well as experiencing stress. So the case management element of our program, as previously mentioned, we offer housing workshops to assist the families in completing the application. So in our first workshop, it's an overview of the Healthy Start and Housing program. We collaborate with the community development program, which provides a tenancy's right presentation and also offers them some tools around budgeting. In our second workshop, we start the Boston Housing Authority application process, and we start to collect and make copies for the families, all of the documents that they need in order, that are required to be submitted for the application process. In the third workshop, the application is completed, and after all the documents are completed, the supplemental documents such as IDs, birth certificates, things of that nature, have been copied, then we submit the application to the Boston Housing Authority. So the other workshops and trainings that we offer to the families to support stable tenancy and family well-being during the 3 years that they're involved in our program. It's financial literacy and coaching, infant CPR, domestic and intimate partner violence, stress, trauma, and self-care, and again, utilizing problem-solving skills, having all of our staff trained, and maintaining the fidelity of the problem-solving education, which is 6 weekly sessions. For our evaluation, it was to monitor and document the process, measures related to the program implementation, assess the feasibility and acceptability of innovative program components designed to address the needs of our homeless families, document the efforts of a tailored home visit model on maternal, child, and family health, and identify barriers and facilitate interagency and cross-sector collaboration. It was a quasi-experimental study. There were home-based or in-person baseline and outcome assessments that conducted at 4, 8, and 12 months after enrollment, after the women were housed in, and then the outcomes, looking at the housing placement, the maternal mental health and social functioning, and maternal health behaviors and parenting practices. And we also conducted some stakeholder interviews, key informant interviews, and documented that process. So our evaluators utilized some of the tools that are identified here in our assessing our clients and in our assessment forms. So in the housing domain, housing barriers, social capital, and homeless history. I'm not going to go through them all, just read the domains. The maternal health and functioning, parenting measures, service use. So the participant housing at referral. So this was some of our preliminary data. 30% of the individuals who were referred to the program were living in a shelter, 11% were renting a room, 31% were doubled up, and 27% were unstable. So the homeless history of the individuals, 59% had been in a shelter or homeless before the enrollment, 40% had a previous episode of homelessness, and 2% total homeless in their life, or actually it's true. And ever doubled up as an adult, couldn't pay the rent, was 89% of our individuals who applied for the program. And the housing barriers at baseline, not having enough income, not being employed or underemployed, no rent history, landlord reference. So problems with police, problems with past landlords, discrimination, family composition, 18%. Transportation to look for housing, things of that nature. So this is an overview of our housing barriers at baseline depression and functioning. So there was no depression for 35%, mild depression 35%, and major depression for 31%. And then the social functioning scores and mental functioning scores of our clients who participated in the program. And we utilized this CESD for our depression screening. So our clients who are housed, this is the racial makeup of the housing, the clients who are housed currently. So we have just under 51% who are black, 2.8% who are white, other 17.76, multi-race, and then we have unknown or declined to answer. That's largely what we found in our population is they decline to answer is historically either someone who is of a black or Latina race for the population that we serve. But that's their option. We give them the option to decline their race. We have had a small number, so we've had a large number of successes, but we had a small number of those who were evicted during this process, and of those, the races are represented here, as well as the age. And what we found with this age group as well was it's an opportunity to look at how we're presenting the program and how can, the goal is just not to give the families housing, it's really around housing retention. In this 18 to 21 year group, we want to look at opportunities to provide them with more support to make sure that we decrease this number of evictions and looking at the reasons why and how do we work with other programs to prepare them to retain the housing. And this is our number of 68 who graduated, and then the races are represented as well as the ages. So the evaluation findings. So the Boston Housing Authority residency requirements disqualified many of the women who met risk criteria. The time needed to complete the housing application and review meant most women were not placed in housing until after their infant was born. So traditionally, it could take up to 5 years in Boston just to have an interview for housing. It depended upon when the women submitted an application. It did take some time, but on average, most of the women were housed within 6 months. But unfortunately, however, most of them had delivered. So we wanted to continue to work with them. That's why we have the 3-year limit to have an opportunity to work with them on birth spacing and looking at the impact of that subsequent birth. Assessing stable housing was very rare without the prioritized placement provided by Healthy Start in Housing. The women were able to maintain positive health behaviors and parenting practices once stably housed. The participants had greater gains in emotional wellness and social functioning. And then trauma was common and a significant predictor in burden on many of the clients that we served. So,
Heavenly, can I interrupt you for a question?
Sure.
There are long waiting lists for public housing in my city. Whereas these 75 housing slots new, if the sites were pre-existing, was there resistance for opening up the sites for pregnant and parenting families?
So the housing slots were within the existing Boston housing development. So there was not new houses that were built for the Healthy Starting Housing clients. They allocated 75 units throughout their development for Healthy Starting Housing clients.
Thank you.
Okay. So just this is for the cost. Our actual cost was the external evaluator and staff training and problem-solving education. For the case management services, we reallocated the duties and functions of existing nurses and community health workers. And when we wanted to look at how much that cost, we looked at two methods in order to, and these I'm sharing with you how we looked at what it would cost us. But we just basically reallocated our duties and functions of the existing nurses and had to also look at their caseloads and how to make sure that they were not overburdened, giving that this was a higher risk population with a 3-year commitment. So for the cost, it was external evaluation and staff training. Programmatic changes. So in order for us to meet the clients where they were and avoid them not being compliant with the home visiting, we changed our program hours of operation from Monday through Friday from 8 a.m. to 5:30, and then we have a Monday, Wednesday, Friday from 8 to 5, and Tuesday and Thursday is a longer day, which is the 8 to 7:30, and we're open 2 Saturdays per month. So the program is feasible from an organizational perspective. It's very labor intensive. The program is acceptable to our clients. The agency's relationship started out positive and got better, and the program is beneficial to the clients in social and emotional well-being. So this is just our timeline. So in the spring of 2011, we proposed the idea of the interagency program. In the summer, we signed a memorandum of agreement. In October, we enrolled our first participant. By October 2016, 106 women were placed in the BHA unit. And then in September, so about 2 weeks ago, we signed a new memorandum of agreement deleting the Boston residency requirement, which was a challenge for a number of the former applicants. And so they deleted that residency requirement, and we now have 5 units that will be dedicated to fathers who will be the primary caregiver of their children who are in protective care, and housing is the only deterrent for reunification. And then this is just, we have a YouTube video also. I know some folks have read the Bringing Life course home, but we also have a client testimonial and an administrative YouTube video.
All right, and I will certainly be sharing the slides so you guys can look at the video, and I will share the contact information for our presenters. So I have a question for Ms. Lillian. For Nashville, what sorts of solutions are being considered by Nashville officials with whom you're discussing the overcrowding problem? And remember to press *7 to unmute yourself.
Well, one of those things that we're doing with those officials is prioritizing for those families to be added to the waiting list. They'll get first preference. Now, it stands as is you get added to the list and you have to wait. And there's about 4,000 people that are on our waiting list for these subsidized housing and for public housing as well. So, and hopefully this will give those families first priority. I forgot to mention, too, that one of the things that we've done here in Nashville is that we've trained in 2 of our public housing sites, we've trained the maintenance workers in the DOSE model, and that stands for Direct on the Scene Education. And so those maintenance workers are able to go in and do an environmental scan of homes that may have infants in it, and to see if those babies are sleeping in safe sleep environments. And if not, we refer them to the health. They refer them to the health department to get those pack and play demonstrations, education, as well as the pack and play.
Thank you, Ms. Lillian. And
you're welcome.
Any questions? Please unmute yourself, pressing *7. And I have a question on the chat box for Heavenly. Was the Healthy Starting Housing model able to reduce the incidence of preterm low birth weights for program participants?
So, as mentioned in the presentation, unfortunately, most of the women receive their housing after giving birth. However, we have looked at the data for those clients who have had a subsequent birth since participating, so the answer is yes for those with a subsequent birth.
Okay. And from Dr. Kim, my question has to do with the recommended square footage per person for good mental health, and if any group is looking at the size of low-income housing units.
In Boston, we're not looking at the square footage per person. That's outside of our domain. What's happening, I don't know if it's happening in other cities, a lot of our public housing is also becoming mixed development. So they are remodeling all of the units so that mixed income individuals can live in these developments. And but the public health in perinatal health services, we're not looking at the square footage. That's outside of our domain at the present time, given that the housing stock is so low. Most families are willing to take anything that they can, because some of them are just they're already doubled up, unstable, or they were living or renting a room in someone's house.
Okay. And Rose is saying that she's not sure if this is happening in St. Louis. To answer your question, Dr. Kim. Okay. Do we have any other questions for our presenters? *7 to unmute yourself.
Hi, this is Allison Yeager from New York City. Can you hear me?
Yes, ma'am.
Great. So I am wondering about in Boston, the willingness on behalf of the Housing Authority to accept your clients as priority tenants. I know here we have a long list of priority categories for public housing, and I'm wondering what were the winning arguments that got your housing authority to agree to bump your clients up to the top of the list?
Well, looking at the previous year, we had our birth outcome rates had taken a tremendous dip. And again, the interagency being under the same administration, so they have a cabinet meeting, and I think their willingness is because housing became more aware that the housing authority became more aware that housing was a social determinant of health. They were also, and by becoming more aware, they wanted to be a part of the solution. So they were willing to try this pilot. Again, it started out as a pilot, and how could we come together jointly to have an impact. So they've worked with other populations here in Boston. So if and yes, there's the domestic violence category. They've worked with individuals who utilize substances, things of that nature. So having a partnership around a specialized priority is not new, but they were open to do that given the significant dip that we had in our birth outcome previous years. So they wanted to help us have an impact on that.
That's helpful. Can I ask a quick follow-up question to that?
Mm-hmm.
Since you mentioned that you're that you're both within the city administration, did you have to get City Hall involved to help broker the conversation in any way, or did it remain at the agency-to-agency level?
It remained at the agency-to-agency level.
Mm-hmm. Okay, that's great. Thank you so much.
Hello?
Yes, we can hear you.
Okay, one question that I have, we're talking about housing authorities, and you're working with them, so in order to address some of our clients, for housing, what about when they sort of like, they have been evicted to, many times they are unemployment, do they still require, help them with housing?
And we're calling from Hartford, by the way.
I'm sorry, yes, we're calling from Hartford.
So for Healthy Start in Housing, it depends upon the reason for eviction. I have to say that the Housing Authority has been willing and open to mitigate certain situations. But you will receive the slides. So if they were evicted for any of the reasons that were listed, there's you know what? That's the slide that you actually could not see. But it depends on the reason. So if they owed it another housing authority in another town, funds, they give them an opportunity. So if there's a rental arrearage, they give them an opportunity to pay that. But there's certain circumstances where they cannot mitigate a situation for which someone was evicted. But I have to say in Boston, an eviction does not disqualify you. It depends upon the reason why you were evicted. Or if you have if you were evicted and still have some outstanding legal issues, and depending upon what they are, that might be a challenge. But they've been really open to mitigate and broker conversations with individuals who've been evicted for various reasons.
Yeah. Another question that I have is just the problem financially, the income. Most of our clients, they don't have any income because they have exhausted all the resources before. So here in Hartford, we're having a lot of problems working with, trying to help them. So going back of being overcrowded, they are, a lot of times, they are overcrowded. They stay in that apartment with the family for 1 month, then they have to move. They keep changing because it's been, many problems that it has been difficult to address, our clients' problems. And, that's one of the concerns that we do have here. I work at the Hispanic Health Council, and I'm a case manager. And one of my work is to work with pregnant moms, and that I see a lot of issues besides, like nutrition and of course diabetes and all that stuff, preeclampsia, and sometimes they cannot meet appointments through prenatal care because of transportation. There's a lot of problems here in the Hartford area pertaining to the pregnant moms and their support and the resources that they have, which they have very little. So, and one of the biggest problems, of course, again, I will address is housing and income, unemployment, and all that stuff, because they don't qualify because of the past history. So that's a concern that we have, and we would like to know how can we help them as much as we can. But it seems like then they sort of like move from one place to the other, which you try to get them and can, or it's been very difficult.
I think this question is also for Heavenly.
So that was one of the reasons why we have this participant agreement. So we want to meet the families where they are and work with them. And again, so if each case is different. So a mom may not have income because of her high-risk pregnancy. We'll work with her to apply for any entitlements that she and her baby may be eligible for. The Housing Authority has been very open in these conversations and ensuring that those women who qualify are able to be housed. It does require a lot of documentation, but a woman going from house to house or spending more or all of her income on just trying to stay in this unstable situation. We document all of that. We submit that, and in our search situations, the Housing Authority has been willing to accept that. There's a little bit more documentation that the client might have to follow up on, but it varies on case by case. But the case management is very important for this program, and that's why we've asked them for a 3-year commitment so that we can meet the challenges that they're experiencing now, minimize the other ones through problem-solving education and with the family development credential, and help them achieve whatever goal that they've identified in their care or service plans.
Heavenly, I have another question on the chat box.
Okay.
What would you consider the most significant achievement of your initiative?
The program. I think just there's not one. I think having this program has been a significant achievement. My most recent, since this, we've embarked upon this journey, I would say, is adding the fathers units, which was the new memorandum of agreement. So adding the fathers, the program itself, knowing that the individuals who participated in our program, who had a subsequent birth, had a better outcome. Those are some of the significant achievements that I can say of our initiative, and that 2 agencies did not need the leader to make us come to the table and agree to work together. That both agencies were open to do that.
Thank you. Do we have any more questions for our presenters? And remember, *7 to unmute yourself. Okay, so what is going to happen next is I am going to be sharing the recording of the webinar with you all, as well as the slides and the contact information for our presenters if you have any follow-up questions. Thank you guys so much for coming. Thank you so much, Heavenly, for taking time out of your day to present. Thank you, Lillian. Thank you, Rose. I really appreciate it. And everyone has a great week, please.
Thank you.
You too.
Bye-bye.
Bye.